Hey, good morning and welcome to Open Mics with Dr. Stites. It's Wednesday, November the 9th. I'm Dr. Steve Stites, Chief Medical Officer here at the University of Kansas Health System. Hey, we all like to step outside on a nice, crisp fall morning. By the way, Friday is going to be a cold, crisp fall morning, and fill our lungs with clean, fresh air. But it's easy to take that for granted, as many people with lung problems have trouble just taking regular breaths. Today we're going to talk about a long-term study of people in their 20s and 30s to find out what causes that type of a lung problem later in life and ways to prevent them in the first place. Joining us here in the Dolph Simons Jr. Family Broadcast Studio are Dr. Cho. Close?
Huang.
I know the Huang part. I was trying to get the first name right. A lung cancer medical oncologist, and Dr. Ali Khan Naji, a thoracic surgeon. And joining us remotely is Heather Fielding Gebhardt, who has signed up for this long-term study of the so-called millennial generation. Questions from our viewers are an important part of this program, and we want to hear from you. Get yours sent in to us now on YouTube, Facebook, Twitter, and the Medical News Network. You'll find those links right here on your screen. Jessica Lovell will join us a little later with those questions. Guys, this is exciting to me. I'm a lung doctor too, so I can actually participate in this conversation, but I think you all have done a lot of work in this area. And I see people all the time who are short of breath later in life, so I'm really excited about this study. And Dr. Huang, this is a pretty ambitious study, a $25 million NIH grant to the American Lung Association. It's going to track 4,000 people between 25 and 35 years old. Tell us, why are we focusing on the millennial generation? What are you hoping to find?
Well, I think the study probably is focused on them because we're seeing lung disease probably earlier in life, especially because of the population, maybe starting smoking even earlier with the electronic cigarettes, as well as the current pollution problems is probably causing not just lung disease, but with the electronic cigarettes probably increasing the incidence of lung cancer and other respiratory diseases. So I think that this study probably will start tracking these patients to see what happens over the long run in terms of incidence of respiratory disease, illnesses, as well as potential risk for lung cancer.
So that's a pretty big study and a pretty big deal, and I think is really important for us to better understand the impact of what's going on around us on things like lung cancer. You mentioned e-cigarettes. Everybody wanted to believe that they're going to be safer. The reality is they're not safer, and in many ways they may even be a little more dangerous.
Right. So I think there's some discussions or studies that show that perhaps the electronic cigarettes may be a substitute to the traditional cigarettes in terms of having less carcinogens, but it still contains nicotine, which is unfortunately highly addictive, and nicotine by itself is also a carcinogen. So even though it may be perhaps have less carcinogens compared to the traditional cigarettes, I think the electronic cigarettes still imposes risk and so forth. And we've seen also case reports of young people smoking this flavor electronic cigarettes causing severe lung reaction and end up in the ICU and so forth. So even though it's touted as a potentially less of an evil compared to traditional cigarettes, I think there's still a lot of risk associated with it.
Well, and I think the question is going to be, what's the threshold of carcinogen needed to cause cancer? And just because we say it has less doesn't mean it has more than enough to do it, which I think is what we're going to find out that the evidence shows. So we put a QR code up on the screen for anyone who would like more information on this study, this long-term study that y'all are doing. One of those who volunteered for this study is joining us remotely. Heather, tell us what made you want to be a part of this very important study, and what is it that you have committed to for this 5 years?
So yeah, I joined the study because I saw a flyer and I was in the age group. So I was like, well, that's great. And I am interested in lung health. So I thought it would be a nice way to kind of contribute to the research community, as I'm a researcher too. So it's always good to have that karma in the community. And then I was like really intrigued to learn more about my lung function and my lung health, as well as be able to contribute to science in general. So it's a 5-year study, which doesn't seem like a huge commitment to me, but I guess for some people it might. But the first visit was like in person at the med center, and it was a couple hours long, and we did a lot of we did some breathing tests, we did like a lung CT scan, some blood draws, lots of questionnaires and stuff like that, like asking like where I'd lived and what kind of potential pollutants I'd been exposed to and things like that. And then I think for the next 5 years, every couple of months, I'll be contacted by the study and I'll do like a remote breathing test and answer some questions.
All right, so you're going to have to be this participant, and it's you've outlined for us what it was like to go into this study and what you're going to have to do. Dr. Wong, what do you hope to gather from that? Are you going to figure out this is what's causing lung cancer, this is what's causing emphysema or asthma? I mean, is it all part of it, or is it just cancer?
I think this study like this magnitude will probably gather much more information than just lung cancer, probably what precipitates some of the respiratory diseases as well as maybe even allergy and other risk factors for other illnesses. So I think not just lung cancer, but I think probably a lot of other respiratory diseases.
Yeah, I think that's a really important point because this is a really broadly focused effort. So Dr. Naji, out of all the cancers, lung cancer remains the most deadly with more than 230,000 new cases a year. But not nearly enough people are getting screened, and research funding is lagging. This has affected my own family. I was 19 years old when my mom died of lung cancer, and she was 52. And my brother had lung cancer as well, and he had that after a lung transplant. Mm-hmm. So this stuff is very real to me. I think it's going to be very real to our audience. Tell us a little bit about the efforts to help turn that around.
So the big thing here is that we have a NCI designated cancer center here, and part of that mission is to make sure that we do appropriate screening. And part of that screening is a lung cancer screening program. And currently the guidelines have changed. What we're looking at right now is essentially if you're between the ages of 50 and 80 years of age, you've smoked approximately 1 pack per day for 20 years, so that's a 20-pack year, or if you want to do the math, a half pack per day for
40 years,
or 2 packs per day for 10 years. However you can get to that number 20, that will actually put you in that 20-pack year category.
And that's kind of a risk factor. That's sort of the place where things start to escalate. Is that right?
I think it's based basically on research to tell you maybe when that threshold and when to be worried. But a key factor is if you're currently smoking or you've quit in the last 15 years. So if you've quit over 20 years ago and you had a 20-pack year, you actually don't qualify for this. So it's actually a matter of when you've quit or if you're currently smoking. So I think it's important to make sure we have those criteria, but that age group is now extended. It had previously been 55 to 77 and is currently now 50 to 80. So it's trying to gather a bigger group of patients.
So a bigger group in order to figure out, and as we know right now, I think the screening is probably underutilized for lung cancer. Is that what you're hearing too?
Definitely. I think that most people are afraid of the unknown, if you will, or kind of find it to be cumbersome. But I think something like that is really important. You need to be involved in your screening, whether it's a colonoscopy, prostate cancer, breast exam. This is just another form of that to help you maybe be preemptive and proactive in your healthcare. Well,
and that is so important. I've said this before. I have prostate cancer, and it was found in a screening process, and now I have to have regular follow-up, and it's well managed. But I got to do things because I got to find it very early, which probably changed, well, I believe it did change the course of the disease for me. Dr. Naji, what are some of the symptoms of lung cancer? I know it's kind of sometimes hard. It doesn't present till late.
Exactly. It's very nonspecific. In fact, it could be something as simple as a cough. It could be, I coughed a lot, had multiple pneumonias, and you're really not understanding why that pneumonia is there, or the pneumonia never goes away. It could be something more severe, as coughing up some blood, or chest pain, things of that nature. It's very nonspecific. But the important part is, if you have those risk factors, if you've been a smoker, to seek that lung cancer screening out, or talk to your primary care physician about it. I think a lot of with electronic medical records, there are things that are coming up that are best practice advisories. So your primary care physician will plug this data in, and it'll actually tell them, hey, you qualify for lung cancer screening. And so I think that's an important aspect to make sure you're advocating for your health and speaking with your primary care physician.
I think that's going to be such a big approach is when those notifications come through an EMR, they can really help us. Talk to us a little bit about the surgical approaches. Not a lot of patients actually qualify for cancer because it shows up so late.
Unfortunately, that is true, Dr. Stites. we hope to help everybody, but unfortunately not everybody can have cancer. Sorry, not everybody can have surgery.
See, I did the same thing.
Yeah, that can happen. We don't want that either. But surgical approaches are actually tailored to the patient. So sometimes they can be the old-fashioned open incision, which we try not to do, but if that's what's needed, we'll do it. Otherwise, we use small incisions, whether they be thoracoscopic with a little camera or robotic even. And we've started the robotic surgery program here at the University of Kansas, and it's been going strong for almost 5 years.
That is a great thing that it has been going on for that long, and the robotic surgery helps, but I know that not everyone can do that. Sometimes it's a pretty big surgery to try and resect it, and recovery can be a little long. Dr. Wong, tell us about the new developments with these things called immunotherapy checkpoint inhibitors. You have to tell us a little bit of what those are and why they're starting to work in lung cancer, because I know for a long time, lung cancer therapy was a little stuck.
Yeah, so the checkpoint inhibitors or immunotherapy is a new class of drug that was developed probably in the last 6-7 years now, and essentially it's trying to use the patient's own immune system to treat the lung cancer. And what we're seeing, not just in lung cancer, but in other diseases like melanoma, renal cell, and even other cancers, that this approach is highly successful. And so in the past, before the discovery of this type of therapy, the survival, the 5-year survival for metastatic disease stage 4 lung cancer was less than 1%. Now with checkpoint inhibitor, the survival, the 5-year survival rate now is reaching 30% or even better. So it's not still great, but you can see from less than 1% to more than 30% or better, this is a significant improvement. And I think they're still researching other ways to enhance this type of therapy and even improve and reduce the side effects.
So that's a big deal. So the checkpoint inhibitors have to some degree revolutionized, I know it's probably a little bit too strong a term for lung cancer, but I've been in medicine for approximately a very long time, and for many years, lung cancer, we're talking about, well, you lived 2 weeks longer or 6 weeks or 3 months longer. Now, 30%, that's a bigger deal. We're starting to see some progress. What's the future hold?
So I think there's a lot of research going into other therapy modulators are trying to enhance the activity of the T cell that's part of the immune system. So there are studies doing that, and also other studies to increase the response to the immune system, like giving interleukins and other chemicals that sort of flame the activity of the immune system. But not only that, also look at the potential side effects of immunotherapy, because with this type of therapy, we sometimes see some very untoward side effects like severe colitis and pneumonitis. So they're also doing research in terms of why patients will have those side effects and what can we do to manage better those side effects.
Yeah, so there is a better future, and we're hearing new things about stuff like CAR T therapy or other types of reprogramming cells. Is that in the future for lung cancer as well? And why has it been harder to crack this nut?
So the CAR T cell therapy is another form of immunotherapy. So the immunotherapy is a broad term in general in which we use immune system to treat the cancer. So CAR T cell therapy is a therapy in which we're harvesting the patient's own T cells, reprogramming them to recognize specific protein in the person's body, in this case, to recognize a cancer cells, and it's been used very successful in leukemias and other types of lymphomas and so forth. Now they're moving this type of strategy to lung cancer and solid tumors. We in fact have a study currently going on, and we're trying to use this type of approach to treat solid cancer, including lung cancer. And I think the issue here is that this type of therapy is very specific. So the CAR T cell, it's almost like you have to make a key for specific keyhole, which is the cancer cell. But if the door changes the keyhole, so if the cancer actually changes the keyhole, that key doesn't work anymore. So that's why some of this approach might still be refined and improved, to try to make it more active in the cancer that's constantly evolving, is not static and so forth.
So, Dr. Nagy, why are some patients not a candidate for surgery? Some patients are.
So unfortunately, when we do see them, they can be at any stage. And Dr. Wong did a good job of explaining that there are stages, and the stages go from 1 to 4. And unfortunately, when you get more advanced in stage, the likelihood that you'd be able to tolerate and/or be able to have surgery has been reduced. So when we can do surgery, it's a combination of trying to make sure that we can treat the cancer, and sometimes it involves using immunotherapy up front or chemotherapy up front followed by surgery, or sometimes it's surgery followed by those treatment options. So it's very individualized. So everybody is an individual and every cancer is different. So we make sure that we treat the patient, not just the disease.
And so you have to be healthy enough to have surgery,
Correct.
like you do with other things. Radiation play much of a role?
It does. So unfortunately, a lot of those patients have lung disease, COPD, and so forth. So some of these patients, unfortunately, wouldn't be a candidate for surgery, and therefore we have radiation therapy. In fact, there's been studies in early stage disease, stage 1, in which they compare surgical radiation approach using a very sophisticated technique called SBRT, or stereotactic body radiation therapy, and compared to a historical outcomes getting surgery. And this study was done at MD Anderson and showed essentially the same overall survival, showing that a non-surgical approach for early stage disease can have the same outcome. And now that the KU has the proton therapy, I think that approach can even be improved by using this new technique. And so I think our radiation department is certainly working on that.
So yeah, it's a really big deal, I think. And but to your point, a lot of my patients with COPD or emphysema, if they've smoked so much, they've had so much lung damage or other causes, then what ends up happening is they're not a candidate for other surgeries because their lung function, they just can't breathe. And then you just take away any degree of their lung function, and then they get even worse. And so then you're left with a really difficult dilemma. So one of the messages out there is, if you're smoking, whether it's cigarettes or e-cigarettes, stop now, because you want to do less and less damage to your lung. We haven't said that yet in the program, but really, man, not smoking is the answer to so much of this. Dr. Wong, there's a small percentage of patients, though, now some people want to think it's really big because they want to still smoke, but the reality is, I think it's a very small percentage of patients who have never smoked can still get cancer, lung cancer. Talk to us about that.
That's correct. So what we're seeing in the past, I think the emphasis has been in smokers who then develop cancer. But what we're seeing is actually a rise in that subgroup of patients that never smoke. These are healthy individuals who are, they're exercising, they eat right, they really don't have any risk factor for lung cancer. And then they develop symptoms of cough, shortness of breath. They usually go to their physician, who are first recognized or diagnosed with possible asthma or some type of respiratory disease, but in further workup then end up developing lung cancer. And so about 15 to 30% of lung cancer are actually never smokers. And those are a very special group of patients in a sense that their type of cancer has a different biology. They usually have this, what we call a genetic mutation. They're only dependent on probably one or even two only genetic changes that drive the growth of their cancer. And those patients usually can be treated with a therapy called oral tyrosine kinase inhibitor, which is essentially a pill that can potentially have a very dramatic response in terms of shrinkage of the tumor and control this cancer for a very long time.
One more reason to not smoke. We can actually treat your lung cancer. There you go.
Better.
Hawkeye, welcome to the nest there. How are you doing, sir? Good morning. I think you've got some numbers for us.
Yeah, we have our COVID count today, and we were kind of going a little bit, maybe not presenting them every day. We've seen somewhat of a trend of on the high
stability,
side.
been kind of the same.
Yeah, and unfortunately it's kind of staying in that low 20s to high teens. Right now we have 21 active infections, 2 in the ICU, 2 in the ventilator, 41 in that recovery period. We also have another graph today just kind of showing our trends over the last few months, just as we talked about, with in the red being more on the high trend for that month, and on the gray or the white showing the low trend for that month. So unfortunately, haven't seen that dip to 0 or 2 cases like we had early on. But again, for the most part, when we have gone back to look at these patients, they have either been not up to date with their boosters, they have not been vaccinated at all, and especially they have significant comorbidities as well.
Yeah, and that's been the story the entire time. I don't think it's going to change. And as people go inside more and more, I think we'll have to, and we see more and more variants. I mean, the B5 strain is no longer the dominant strain in the United States. And there's kind of this potpourri of other things out there. So it's going to be an interesting few months. If you look at the heat map for just a minute, it's starting to get a little, we're starting to see it light up again. For a while, it had gone all light yellow. But now, if you just watch the national numbers, the new hospitalizations and the new cases are trending up. The heat map shows that, Hawk.
Yeah, exactly. And I think that is our concern. I was looking at some other countries' case counts yesterday, and we know that we tend to lag, but behind other countries, particularly the UK or other European countries, South Africa, et cetera, as well. And right now, all of their cases are fairly low, but starting to climb up. So just as this heat map may be showing, I think we would predict an increase in cases, hopefully not that large surge in hospitalizations and severe disease, though.
I sure hope so, because hospitals are already really full.
Absolutely.
The pediatric hospitals are incredibly full with RSV all across the country, here in Kansas City and everywhere around the nation. And so if you add more insult to those injuries, I think we're going to have a really difficult winter. But we'll see.
Yeah.
Hopefully things will stay a little lower than they look. And that's important, because you don't want to be really sick. Then in one of the new medical headlines that was just published yesterday, the unintended consequences of using a ventilator. This is actually not new news,
right? But
they demonstrated through a different model. It used to be we just pushed air into the lung and we'd sucked it back out. Man, I spent years in the ICU doing that. And then some research started coming out in the mid to late 90s that said, we ought to watch and see how much pressure we're doing, because normally when we take a breath, we create negative force. So it sucks air into our lungs. Ventilators push air into our lung. It's a very different physiology. And what we know is if we push too hard, or honestly, if we just push at all, we're probably causing some injury to the lung and to the airway and to the air sacs themselves, which can lead to what we call overstretching and some long-term lung damage. The way to avoid that, keep yourself healthy. Exercise, don't smoke, get your vaccinations, and stay out of the ICU, because the technologies we have, while life-saving, ventilators clearly save lives, they can also induce some long-term damage to a lung.
And I would say too, when you go into the ICU as a resident or a student, those are one of the first things that you're taught is that ventilator care, taking care to understand all of those pressures for just that reason as well.
Yeah, we've stressed it now for over 2 decades, but man, we still know, Najee, it can cause trouble. All right, Jess, we're going to turn to you. What questions are out there with our viewers today? Hey, Jess, nice hair look today, too.
Oh, thanks. You always know. Good guy noticing the girl's hair. Appreciate
Okay, just somebody knows I was messing with Jess before the program, just for this, and we still might have to follow up on that.
I know, you barely recognized me, but it's because we haven't seen each other in a while, so good to see you. So, Logan wants to know from Heather if there are any restrictions placed on you for the duration of this study.
Heather?
Not that I'm aware of.
You can go party, you can smoke. No, you can't, don't do that. But you could smoke if you want to, bad idea. But you can go, water skiing. You can do anything you want, right?
Yes, that's my understanding.
Okay.
Yep.
Shirley says, my mother died of lung cancer. Dr. Stites, you had mentioned your mother passed away as well. Her mother had never smoked. Is there a hereditary factor that she should be screened for?
Oh, great question.
So at the moment, we don't have a gene that we have identified, like in breast cancer, the BRCA genes, but there's been some research looking at one of the mutations called EGFR, specifically the T790 mutation variant, that could be a genetic component. And so and right now, there's no recommendation to screen patients for a hereditary gene, but if the patient comes back and tests positive for EGFR, specifically if they have this T790M variant, it's recommended that this patient then undergo genetic counseling to then test potentially other family members to see if there is also a familial component.
Okay.
Jess?
I'm looking. Okay, Adrian says, what about pot smoking?
Oh, pot smoking.
My friend doesn't smoke cigarettes. My friend doesn't smoke cigarettes, but has heavily smoked pot for years. What type of risk?
Risks.
Yeah.
I'm not a pulmonologist, so you may know more about it.
Yeah.
But I think there's still probably some carcinogens in it. There's research that's showing that the marijuana may have some medical beneficial effect, but I think we still don't know what are the potential carcinogens that might be in those.
Yeah, I think it comes down to there are multiple layers to this question. Is heavy smoking making you're doing one a day, one cigarette, or one, and how much are you doing in that one time? Are you combining with edibles? I mean, there's just so many questions. Also, the degree of purity you're getting, what are the additive ingredients inside the marijuana that you're smoking? All those things impact the answer to that question. Here's what we know. Think about smoking like walking into a bar filled with thick smoke, or into a fire. You know what? You walk into those things and think about the stuff you're breathing in, and then ask yourself, why would my lungs like it when I breathe it in from smoking? And the answer is they don't, right? They just don't. And all that stuff gets deposited into your airway, and then your body has to try to clean it out. And when it cleans it out, it gets engulfed in cells, and then the material itself causes damage to the airway, to the cells that line the airway, and to the cells just on the other side of the airway, and onto the little vacuum cleaner cells. All those things can get damaged, and then they can start developing into tumors. And so and that's sort of a very high level view of it, but think of any form of smoking as walking into a smoke-filled bar and ask yourself, is that something my lungs are going to be happy about? So my answer to the question about marijuana is there's a whole lot of variables in there that make it hard to say exactly. In general, marijuana smokers don't smoke as much as tobacco smokers do. But for those of you who are going to smoke, have a 20-pack year history, do it especially over a short period of time, yes, you will start to develop all sorts of lung disease, asthma, emphysema, and lung cancer.
Steve, can I also add from the ID standpoint as well? I mean, it's pretty well documented also when smoking marijuana, especially if later in life you have a problem like cancer or leukemia, you can get infections from that, most notably things like aspergillus, which are just environmental fungus. However, when you do smoke marijuana, the temperature of the flame is not high enough to kill those spores, and so you do breathe them into your lungs. So there are well-documented infections associated with that, especially if you become immune compromised later in life.
Yeah, I think that's a great point, Hawkeye, and it has to do, again, a lot of people do this coming out of their own backyard. They have their own plants and grow their own marijuana and smoke it. And again, it's a whole different process like that, and it becomes widely variable. So, yes.
All right, I had to ask. So what about vaping? And what about secondhand smoke? What are those risks?
Let's talk about that. Vaping is kind of the e-cigarette thing. We sort of address that. Bad news for your lungs, bad news for asthma, bad news for emphysema, bad news for lung disease in general, and bad news for lung cancer. You talked about that.
Right. I mean, I think there's still risk, definitely risk with vaping. I think there is, as I mentioned before, there probably has less carcinogens compared to normal cigarettes, but there's still the nicotine and a very high temperature vapors that go through the lung that can potentially cause injury. And as Dr. Stites mentioned, that can cause chronic inflammation, which can sometimes then eventually turn into a cancer, a carcinogenic process. Secondhand smoking has been documented to be also another risk factor. So, and that's why there's all these regulations about avoiding smoking in office areas and so forth. So I think it's still a potential risk factor, and I think I would definitely avoid it if you're not a smoker.
Very strongly considered, and potential problems for asthma, COPD, etc. And so I think one of the challenges for a lot of us grew up with our parents. Both my parents, as I mentioned, my mom died. She had a long smoking history. My dad had he ended up with terrible emphysema. The car windows were rolled up. They were always smoking inside the house. Did that give me a risk for lung cancer?
I think it depends on the degree of the exposure and for how long, right? I mean, secondhand smoking is essentially the person is breathing almost the same amount, well, maybe not the same amount, but the same carcinogens that's in the air, and then eventually those carcinogens can cause their injury and carcinogenesis. So I think it's highly depending on how long the person has been exposed, the degree of exposure. You know, did the smoking exposure started during their infancy? Was it later in life? And was it on a regular basis or once in a while? So there's a lot of variables that could potentially impact. So it's hard for me to tell you exactly how much.
Yeah. Well, fortunately, when I left at 18 years old, they smoked a lot. I left at 18, and I never had smoking in my house thereafter. It was not something we liked. Heather, are you a smoker? Good choice. No. I'm going to ask you to talk about e-cigarettes, vaping, any of that kind of stuff?
Nope.
Excellent. So hopefully you will be a very boring study participant. I don't mean that on your personal life, by the way. I'm just saying in terms of your medical history, that's a good place to be. All right. Jess.
And Dr. Stites, I'm with you. I remember I grew up in a house. My parents smoked, or my mother smoked, with the windows rolled up. I mean, smoking in the house. It was all day, all night. Glad those days are behind me. Yeah, times have changed. So, Dr. Nagy, one of your patients, Cindy, wrote in, and I have to share this with you. She said, please tell the doctor, because of him, I'm down 40 pounds. The beer is gone, walking 10,000 steps a day. She said you put her on a challenge after her diagnosis, and she's doing great. She cannot wait to turn 65 in February. So,
wow.
It's great to hear.
Do you always have those good results? That's impressive.
I'm sure everybody does well.
All right, Jess.
Okay, so Christy has a question. She says, I'm just going to read this because I think it's a good one. So kind of sift through it with me. I quit smoking 7 years ago, and previously to that, I had quit 8 years. I'm still currently not smoking. However, I did smoke a pack a day for 20 years of my life. So she got a preventative lung cancer screening, and it shows that she has mild emphysema. Her first question, is there anything she can do to increase her lung health now? And then she's got a follow-up question.
Yeah, the best thing you can do is make sure you never smoke, take good care of yourself, exercise, 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 and you will improve your You don't really recover lung, but you can compensate for it if you really work at exercising and putting yourself in good cardiorespiratory shape.
100% agree. Unfortunately, like other organs, the liver can regenerate, but the lung can't. What you start off with is what you're going to only work with through life. So the more damage you do, it's not recoverable. But exercising 30 minutes a day, ideally, brisk walks, and taking nice deep breaths and making sure that you're always in good health, avoiding any smog, particles, smoking, things that are just have those types of issues. And if you have any concerns, questions, advocate for your health. Talk to your primary care physician. They may need you to see a pulmonologist to help you out. But I think that that's important.
Yeah, just to say, you can lose a fair amount of your lung function and still be incredibly active. I have people who had an FEV1, that is how much air you can breathe in and out. They lost about 40% of their lung function and still did a marathon. I'm not going to tell you they did it in 2 hours, but they did it. And so you can still be very active. You start getting down to around 50 and 40%, you're going to feel it. And by the time you hit 30, you're going to be thinking, I can't breathe. And around 2025, we're going to start talking, actually around 30, we're going to start talking about transplant. So, I mean, you really, fight for every breath you've got, Jess.
So I'm going to wrap up with this. So just confirm with her. She said she was told that she needs to go back in 6 months to make sure that the nodules that she had aren't growing. But she says that's the extent of what she has been told for her follow-up. Do we agree with that as far as that being a good lung health plan for her, she's wondering?
100%. I think that it's important that what we have is just like a female who has a mammogram, they get a BI-RAD score, so they'll tell you, hey, we're worried about this, this is our recommendation for that. We also have something called a lung RAD score, and that's based upon data that says if you have this type of nodule or this size of nodule or this many nodules, we would recommend a 3-month, 6-month, 1-year follow-up. So whatever that recommendation is important to follow.
All right. Well, this has been a great program today, and I always enjoy the opportunity to talk about stuff that I actually know a little bit about, as opposed to some of this other weird stuff. And I'm like, gosh, do I really know anything about that? I don't know. But at least this whole lung cancer, thoracic surgery, we're kind of in the element here. Let's get some final thoughts from everybody. I'm going to start, Dr. Wong, with you. First of all, thanks for being on the program. Thanks for this great study. I want to be alive when the outcome of this study is known. So that means you guys got to keep me alive for another 25 years.
Yeah, so some final thoughts is that lung cancer is a silent killer. Unfortunately, a lot of the patients, they don't have symptoms, so it's important to do the screening. And I know a lot of patients have their fear that they're going to go get a lung cancer screening and they're going to find lung cancer. And I think view that as a lung checkup, because you're not just checking for lung cancer, you're checking if you have emphysema, if you have nodules, or some other illness going on in your lung. So view that more as a lung checkup. And again, talk with your co-workers, family members that smoke. Try to encourage them to quit and do the lung cancer screening.
All right. Well, that great advice, and clearly we need people to do that. Lung cancer screening is really important. The earlier we do get to this, the faster and the better we can treat it.
I would just like to echo what Dr. Wong said. Definitely agree with that. Be an advocate for your own health, whether that's for the lung or for any other part of your body. Make sure that you visit with your primary care physician, that you discuss things with your family, and have that open conversation. The better you are having that conversation with your family, the better for all of your family.
Huck.
Nothing more to add. Again, this affects so many people, so many families, so many lives. It's great to have these two physicians here working with these teams, collaborating with them every day. So.
Jess, I'm reminded of that song about every breath I take, or is every breath you take. When you watch people struggle to breathe, it is one of the hardest things. So I want to say thank you to Heather for being a part of this study, because it's going to help us understand why people have a hard time breathing. Heather, final thoughts from you.
No, I'm just excited to see how the study goes and be part of it.
Well, thank you for doing it. We're excited to have you in it. I often like to say live long and prosper, and it's a Star Trek thing, so of course I do. But at the end of the day, living long and prospering means you want to have good health. And one of the key things to have health is to be able to breathe. So take care of yourself by taking care of your lungs, so that every breath you take is a good breath. Jess, back to you.
All right, Dr. Stites, thank you so much, and thank all of you for joining us today. Great program, great guest. We'll, of course, be back tomorrow morning at 8 with another episode of Morning Medical Update. So go out, make it a great day. We'll see you back here tomorrow at 8. Coming up tomorrow on the Morning Medical Update. Imagine giving birth to a healthy baby and remembering none of it. That's what happened to this mom put into a coma after suffering a brain bleed caused by a tangle of blood vessels. I'm Jessica Lovell. Join us on the next Morning Medical Update for this story and meet the doctors keeping mom healthy. See you Thursday at 8. I'm Alexis Del Cid on the next All Things Heart.
I've heard of all type of cancers, but I never heard of multiple myeloma.
And the very treatments meant to cure him could cause his heart to fail. How doctors were able to guide him safely through his epic battle for life. Thursday morning at 10.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcasts. Now everywhere podcasts are available.